Hi, welcome to our Columbia St. Mary's Bariatric Surgery Informational Seminar. I'm Dr. Regan. We always start our seminar by discussing body mass index, or the calculation based on weight and height. A normal body mass index is typically 20 to 25. We start to consider patients for surgery once their body mass index reaches 35. Patients can qualify for surgery if their body mass index is 40 or greater, just based on that number by itself. If the body mass index is 35 to 40, patients can still potentially qualify, but typically health problems or diseases related to obesity are required. What does it mean to have a BMI or body mass index of 40? Height of 5'2" gives a weight of 218, 5'6", 247, and 5'10", 278. Another way to think about that is if your BMI is 40 and you're of average height, you have 100 pounds of excess weight, or you're 100 pounds over an ideal body weight. These are some of the health issues. Again, particularly in that BMI of 35 to 40 category, at least one of these is typically necessary to qualify for surgery. Diabetes, taking medication for high blood pressure, using a machine to help you sleep at night, either a CPAP or BiPAP for obstructive sleep apnea, taking medication for cholesterol, having heart problems, or significant joint issues. So again, if you're in that 35 to 40 category, at least one of these is typically necessary. Other requirements for surgery: we need to document that you've tried other things. That can include diet, medication, exercise programs, perhaps meeting with a dietitian. We clearly want you to be well informed and motivated. This is a life-altering decision to have bariatric surgery. You have to have appropriate expectations about what the weight loss will be, and we'll talk about that in a few minutes. And really, most importantly, is you have to understand that the procedure is a tool for weight loss, and that lifestyle change and things that you change are really a critical component of success. We do like to follow patients for 5 years after surgery. We chart the weight loss results during that time. There are some supplements or vitamins that patients will take after surgery, and we like to check those levels periodically during that 5-year period. Any abdominal surgery that requires a general anesthetic has some risk associated with it, and the bariatric surgery is no different. And we'll talk about that with a separate slide in a few minutes. We will offer the surgery to patients over 18. We do not have an upper age limit. We'll typically evaluate patients on an individual basis. Certainly multiple patients in their 60s have had surgery through our program, and even a handful in their 70s. Again, everybody's looked at on an individual basis. Insurance coverage is probably the most difficult part of the process at this point. The state of Wisconsin does not have a mandate for bariatric surgery, so many insurance plans do not have coverage for bariatric surgery. So it's important that you call your insurance company, make sure that there's coverage or that there's not an exclusion for bariatric surgery prior to coming in for an appointment. When you call for your appointment, we will also contact your insurance company to find out exactly what their requirements are. Every insurance plan is typically different, and many of the plans now require that we see you for 6 months before they will approve the surgery. So that typically will mean a monthly visit with the surgeon and with the dietitian over a 6-month period. We do participate in a program, a national program called BLISS, which is for patients that are considering paying cash for surgery. This is some added insurance. Again, it's a national program. So if a patient has a complication or has to be readmitted to the hospital after surgery, then this BLISS program would cover that admission when other insurance may not. So that's an added program for patients considering paying cash. Now we'll take a couple of slides here to talk about the operations that are available. All of our surgeries typically are done laparoscopically, so it's the small incisions, typically 5 small incisions. This is the laparoscopic gastric bypass, or the Roux-en-Y gastric bypass. It's really the gold standard for weight loss surgery in this country. It's been around since the 1960s. And this really has 2 components that lead to the weight loss, and this is a picture of the anatomy that we see after the surgery is done. So first, there's the creation of the small stomach pouch here. This is the restrictive part of the operation. The smaller stomach is what leads to smaller portions. And then we come down here and we cut the intestine and bring a loop of it up here and attach it to the pouch, and then we reattach the intestine down here. so that this portion of the stomach and this portion of the intestine is bypassed. And that's the second component that assists with weight loss. There's some changes in absorption and some changes in hormone levels that also contribute to the weight loss. So you can see the food trail here is these blue arrows as it moves through here and bypasses the other portion of the GI tract. So a little more complex surgery, as you can see from the picture, but does have the most consistent weight loss of all the procedures, and is also the most aggressive procedure for the treatment of diabetes. The next procedure we have is the adjustable gastric band, or the lap band. So this is a device that's placed around the upper part of the stomach to help control portions and restrict intake. This is the band itself here, which locks in place around the upper part of the stomach, and it has these cushions in place which fill with saline to narrow the diameter of the opening. That saline is injected through a small port here, which is underneath the skin and the abdominal wall, and you have these adjustments done periodically after surgery to add saline and narrow the opening in the lap band. This is what it looks like when it's in place in the stomach. You can see that the band locks in place around the upper part of the stomach, leading to the small stomach pouch, then the tubing that comes out, and the port, which is again located in the abdominal wall. So a much simpler technical operation than the gastric bypass, but does have lower weight loss results, and we'll talk about that some more in a few minutes. Next is the sleeve gastrectomy. This has become one of the most popular operations now as it's developed over the last few years. This is also a restrictive operation where a portion of the stomach is removed, leaving behind a long, narrow tube shape to the stomach. That's why it's called a sleeve, because it's shaped like a sleeve. You can see the shape right here. It's a long, narrow tube removing about 2/3 or 3/4 of the outer portion of the stomach. So a restrictive operation, smaller stomach means smaller portions, and that's what contributes to the weight loss. This is a nice compromise between the other two operations. It's not as complicated as the gastric bypass, perhaps a little bit less weight loss than the gastric bypass, but typically works better than the lap band in terms of long-term weight loss. So 3 different options. It can sometimes be difficult to determine which is the best option for a patient, and that's why researching all of the operations and coming in to meet with your surgeon and talk about the different options is what's critical. The preoperative workup, beforehand, you'll come for your initial visit. You'll meet with one of our nurses who will do an intake and document your health history. You'll meet with your surgeon to talk about the different surgical options, and also to go through your insurance requirements to come up with that roadmap for how long it's going to take to get through the process. And then you also meet with the dietitian. The number of visits that are required through our center is really determined by the insurance requirements, and every plan again is different. Sometimes it's 6 months, sometimes it's 2 months, but we'll work with you to determine what that's going to be, and you should have an idea of that during your first visit. Everybody undergoes some sort of medical clearance during that workup time. We'll coordinate that with your primary physician. You may have to have a stress test or a heart workup, for example. You may be evaluated for sleep apnea if we have significant concerns. And then all patients, as an insurance requirement, also must undergo a one-time psychological visit or evaluation, and we can help schedule that. It's usually not a complicated process, but again, that's another insurance requirement as you move through the process. Patients that are having gastric bypass surgery typically require an upper endoscopy, otherwise known as an EGD, before surgery. That's done by one of our GI doctors. Typically it requires some sedation, and a scope is put down into the stomach to take a look and make sure that there are no issues prior to surgery. So all gastric bypass patients are required to have that beforehand, and some of the sleeve patients are required to do that based on potential history of reflux or heartburn issues. So this is a basic outline of the workup that's required. Relatively simple, but it's based on the patient's individual history. And again, the number of visits or the number of months that it takes is really determined by the insurance requirements. In the hospital, the stay is typically 1 to 2 days. The operations themselves take 1 to 2 hours. Pain control is obviously important. The incisions are small, but they can still be uncomfortable. And so we use different methods for pain control. You may have a pump where you'll push a button to deliver pain medicine. You may have a liquid form of pain medicine that you take. If you do have a CPAP or a BiPAP for sleep apnea, you'll bring that with you to the hospital and use it in the hospital. Getting patients up walking is one of our most important things after surgery. We want to prevent blood clots, and so we encourage patients to walk frequently and relatively quickly after surgery. You'll also wear some inflatable leg boots while you're in bed after surgery to help with circulation. They'll be on you for your operation as well, again trying to prevent blood clots in the time after surgery. The diets after surgery, we call them stage 1, 2, and 3. The stage 1 diet is what we really promote the most in the early period after surgery, even the first week after surgery. This is a liquid, low-fat, low-sugar diet. It's made up of Jell-O, juice, G2 Gatorade, water, obviously, broth. And that's really what we emphasize. When you're recovering from surgery and your stomach is small, it's hard to stay hydrated. You have to drink frequently and multiple times every day. And so we really work on and encourage that stage 1 diet. That's the most critical part of the process afterwards. When you go home, you'll focus on the same things as in the hospital. You'll be doing your walking, working on staying hydrated and drinking frequently, and then slowly advancing to our other diets. Again, stage 2, which is a pureed diet, stage 3, which is regular diet. You'll transition to those over a period of time, and the dietitian helps you with that process of transition. If you take a lot of medications, it can be difficult after surgery, especially in the first couple of weeks, to take all of those medications. So we will restrict some of your medicines or hold some of them initially after surgery. If there are critical medicines that are very large pills, we'll have you break them in a couple of pieces to make it easier to swallow. Our supplements or the vitamins, we'll talk about that with a separate slide in a second here, but we will usually start those, at least one of those, when you go home from the hospital, and then we start additional ones after the follow-up visit. Time off of work or school, typically 2 to 3 weeks is the most common time period off of work or school. It depends on whether you do heavy work at your job. It depends how you feel in terms of the recovery process, but in general, a 2 to 3 week time period is most typical. Follow-up visits for the gastric bypass and sleeve, they're very similar. We'll typically see you 3 weeks after surgery, 6 months, and then yearly for 5 years. We may see you a bit more frequently if you have diabetes or significant blood pressure issues. And you'll typically have a 3-month visit with the dietitian as well. The dietitian sees you at all of the visits, but also as a separate visit at 3 months. The lap band requires a little more frequent follow-up because of the adjustments, and those are typically done every month or so for the first 6 months. The dietitian, again, is available at all of these visits. We have some additional post-operative sessions that are available. We have counseling sessions. We have support group that meets a couple of times a month in the evenings. And we have a mentoring program where you can be paired with somebody that's already had surgery. Our Way to Go exercise program is offered for post-operative bariatric patients, again, just for patients that have had surgery as a nice way to find an exercise group. And then most patients are interested in excess skin. Will it be an issue? Will plastic surgery be required? We do have plastic surgeons available for consultation. All patients that have weight loss surgery typically have some degree of excess skin. It's difficult sometimes to predict how much of an issue it potentially will be. Sometimes insurance will not cover plastic surgery afterwards. And so what's most important, I think, is to understand we wait 12 to 18 months until we determine if that's something to be evaluated for. We wait till the weight loss is completed before being considered for any potential surgery. And I do think that most patients find that the excess skin is not as much of an issue as they thought it would be, but certainly those consultations with plastic surgeons are available. The vitamins that we touched on briefly before, the gastric bypass requires the most vitamins. It's typically a multivitamin, an iron pill, vitamin D that's usually combined with a calcium, and a B12. The sleeve and the lap band require the same vitamins, except the iron is typically not required, and often the B12 can be stopped after we check it in 6 months. So the idea is to start these medications or supplements after you've recovered a bit from surgery, continue them for 6 months, and then do lab work to make sure that those levels are okay. In addition, the patients that have a sleeve or a gastric bypass will also take a medication to help prevent gallstones from forming in their gallbladder. When you lose weight rapidly, like you do with those 2 operations, you're more likely to form gallstones, and those can cause symptoms. So we treat with a medication, it's called Actigol. We do that for 6 months, and we start it at your 3-week visit when you come back to see us. And that reduces the risk of forming gallstones. Now, if you don't have your gallbladder, if you've already had it removed, you don't need to worry about the medication. This slide, I like to take a couple of minutes to just talk about potential complications or issues that can develop after surgery. This is really a critical part of understanding the risk associated with surgery, part of the informed consent process. On the left-hand side is a few things that can potentially happen with any surgery, abdominal surgery that you have. You could get pneumonia, you could have a wound infection at one of the incision sites, you could develop a hernia at one of those sites, or you could have an issue with bleeding. And I don't think the bariatric procedures are much different than other procedures, such as a hysterectomy or having your gallbladder removed. On the right-hand side is a list of a few things that are more specific to the bariatric procedure. The first couple relate to the gastric bypass. The first here we list is stricture and ulcer. At that location where we attach the stomach pouch to the intestine, that's a small little circle, about 1 centimeter in diameter. And some patients, as they heal that area, form scar tissue and narrows that opening to a little pinhole. That develops into what we call a stricture. Typically, it happens about 4 to 6 weeks after surgery, where you're starting to have more difficulty tolerating food. And what we do is have one of the GI doctors get involved again, and they put a scope down in that area, and they can dilate the narrowed area with a balloon. Happens a couple % of the time, so relatively common, but again, also relatively easy to treat. The other thing that can happen in that area is ulcer formation can occur. That area is prone to ulcer formation. And so we counsel patients to not take anti-inflammatory medications after the gastric bypass because of the risk for ulcer formation. Second on the list there is dumping syndrome. This is really a side effect of the gastric bypass surgery. So because of the way the anatomy is done, if patients take in a high concentration of sugars, if they eat a dessert or something that's very sweet, they're going to undergo dumping syndrome or have symptoms of dumping syndrome. And it's quite miserable. It can be a whole constellation of things. It can be chest pain, sweats, palpitations, abdominal pain, diarrhea, vomiting. It usually lasts for an hour or two and then it resolves. Some patients actually think of it as a positive because if they struggle with sweets, this can be a deterrent to the intake of sweets. Again, it's only a side effect from the gastric bypass surgery. It doesn't mean that there's anything wrong, but it is a constellation of symptoms that can develop after the intake of sweets. We place pregnancy on the list here more because we advise patients to not become pregnant during the time after surgery. We say 18 months for a couple of reasons. Number one, if you're losing weight and then become pregnant, you're going to shortchange your weight loss results because you gain weight from a pregnancy. And then number two, there is some risk to the baby if you become pregnant during the negative balance time or the weight loss time of your bariatric surgery. Now, after the 18 months, typically pregnancies are more successful. It's easier to become pregnant and the babies are healthier. But again, you really do need to wait that 12 to 18 month period. Potential for band complications. The band is a relatively simple initial procedure, but there can be issues that develop longer term. Most commonly is we have issues with the port underneath the abdominal wall that can be damaged by the multiple needle sticks and have to be replaced. Sometimes it can even flip over and have to have a minor procedure done to place it in the right position. And those are usually minor procedures. More significantly, the band can slip on the stomach, a band slippage, and that can require another laparoscopic procedure to address that. So it is important to recognize, although it's a very simple operation up front, there can be some issues that develop longer term. And then finally, the mortality rate. This is somewhat difficult sometimes to talk about, but I think is really a critical part of this process. Anybody that has abdominal surgery and has a general anesthetic, there is a mortality rate associated with that operation. And the bariatric procedures are no different. The documented mortality rate for these procedures is about 1 in 1,000 to 1 in 500 patients, 0.1 to 0.2%. And that's a low number, but it's certainly not zero. And there are two issues that potentially can lead to mortality that are listed here. The first is a staple line leak. So anywhere that we staple the stomach or staple the intestine, if that staple line fails and you have leakage of the contents from inside the stomach or intestine to the outside, that can make patients very ill and require additional surgery, require ICU stay, antibiotics. and really can be a dramatic complication after surgery. And so the way that we approach that is that we're always looking for it. In the operating room, we'll do a leak test to make sure that everything is watertight before we're finished. And if we have any concerns after surgery, we do x-rays to look for a potential leak. Because the idea is if you find it and pick up on it early and address it and go back to the operating room to address it, then that can be much less consequential for a patient as opposed to it being missed for a few days. The risk for that complication is only really in the first week or first few days after surgery. That's why we keep you in the hospital for a couple of days to make sure that everything is okay. And again, don't hesitate to reoperate if we have concerns about that issue. The second thing listed here is pulmonary embolism, and this is a blood clot that typically starts in the legs and can move up to the lungs and can cause mortality after surgery. Being obese puts you at risk for that. Having surgery puts you at risk for that. So we do several things to reduce that risk. We talked about already getting up and walking soon after surgery. We talked about the leg boots that will help with circulation in your lower legs. And also we treat you with low-dose blood thinner while you're in the hospital to reduce that risk. It doesn't take the risk to zero, but it keeps it at a very low number by doing those things. So these are somewhat difficult things to talk about, kind of scary to talk about. All of them individually are very low risk for patients. These are very safe operations, but it is important to have some understanding of these things as part of the decision making to have weight loss surgery. So what can you expect in terms of the weight loss? With the gastric bypass, we see about 70% of excess weight being lost at about a year after surgery. So if you go back to the BMI of 40 patient, they have 100 pounds of excess weight, they're on average going to lose about 70 pounds. The sleeve is a little bit less at about 60% or 60 pounds in a BMI of 40 patient, and it takes about a year to see that final result. The band is even a little bit less than that, it's about 50% of excess weight loss, and it takes 2 years to see that result typically. So that would be 50 pounds in a BMI of 40 patient. I think more importantly than those numbers is that we see reversal or improvement in over 90% of the diseases or health issues related to obesity, and that's really the critical part here. We try not to emphasize the weight loss numbers as much anymore. They're sometimes hard to predict. We can give you sort of an average, but for the individual patient, it can be difficult to predict what exactly the weight loss number will be. Patients often have a goal in mind, but that may not be realistic. And really what's most critical is that we help patients get healthier. If you lose 50 pounds, but your diabetes goes away, then that's certainly a big improvement and a big change. We're trying to help patients get healthier, live longer with weight loss surgery. And then finally on this slide, the regaining of weight after surgery. You may know family or friends that have had weight loss surgery and has regained some or all of their weight after surgery. And I think that's a risk for any of the operations. That can happen. I tell patients there's a 15 to 20% chance that you'll regain the weight that you lost after surgery. And typically that's not a technical failure of the operation, but is more related to behavioral issues. Patients go back to bad habits. They may do snacking. They may start eating multiple meals. They may start to make poor food choices. They may not be physically active. And when those things start to creep back in, then some of the weight can come back. And again, I think it's a risk really for any of the procedures. The timing of it may differ for different procedures, but there's a real risk for that. And it's important to understand that. And that goes to the point that lifestyle change must go along with having bariatric surgery. That's the only way to be successful long term. So our bariatric center is located at the Columbia St. Mary's Milwaukee campus on Lake Drive and North Avenue. We have inpatient and outpatient facilities. So we have a clinic where we'll see patients before and after surgery, and then obviously the operating rooms and the post-operative floor where patients go afterwards. We really use a team approach to this. Everybody you meet in the hospital has taken care of bariatric patients, has experience taking care of bariatric patients and some of their specific needs. And that's really a critical part of this. We're very proud of our safety record here and the experience that we offer for bariatric patients. Our phone number is listed here at 962-2274. We certainly welcome your phone calls with questions or potential appointments. We also have a website at milwaukeebariatricsurgery.com. And what I would emphasize is the more research you do, the better. The more you learn about bariatric surgery, the more people you talk to, the more internet research you do, the better. Those patients have come armed with questions, and I think are better prepared to have surgery and to come for their initial consultation when they've learned about this, talk to patients about it. The more you learn, the better. So thank you for your attention, and this concludes the Columbia St. Mary's Bariatric Surgery Informational Seminar.